Testing 1, 2. Hello, I'm Dr. Gerald Boey, speaking to you regarding treating pigmented lesions by laser. I have about a 30-year history of treating lesions by laser, and started both a laser clinic in Saskatchewan and moved to Vancouver in 1992 and established the Arbutus Laser Center. I've been doing this most of my life, and I have quite a passion for it. So what will I discuss today? What is a laser? Why do lasers work for pigmented lesions? What's available in the marketplace out there for treating pigmented lesions? What can I hope to achieve with lasers? And what can I not achieve using lasers for pigmented lesions? And I'll also briefly discuss some of the complications that can arise from treating pigmented lesions by laser. So why do we use lasers? Why lasers as opposed to other technologies? Well, they're cool. Everybody has seen this, and it's certainly in the public eye. People come in asking for lasers. Specifically lasers, sometimes even the specific laser that they want. They've heard or read in mainstream media, social media, that lasers are quite effective for treating lesions, specifically in this case, pigmented lesions. And what's the most important reason that we use lasers? Well, they work. Starting about 30 years ago or so, lasers became more and more specific for in the ability to target certain lesions, whether it's vascular or pigmented in this case. This is something my daughter made during the science project in grade 6, which briefly outlines what a laser does. And what makes a laser unique is that it's monochromatic. It's only one wavelength. It's collimated, so the laser beams don't spread out. They go in a very straight line, coherent, as opposed to ordinary light. And in this case, even IPL, which is really a broadband of light, multiple wavelengths, polychromatic, the light spreads out in all directions. Here's the electromagnetic spectrum, and the lasers that we're mainly interested in are in the green and red wavelength range. It's not that we can't use other types of lasers, specifically erbium and CO2 lasers are used for pigmented lesions also, but they're non-specific. What is the, what characteristics do lasers have that make them unique also is the wavelength and the depth of penetration. The longer the wavelength in general, the deeper the penetration for lasers, until you get into the wavelengths that are mainly absorbed in water, which is the erbium and CO2 lasers. So generally, the longer the wavelength, the deeper the penetration. This is a nice sketch of the relative absorption of these wavelengths in different colors. So for hemoglobin, oxyhemoglobin, we get a strong absorption in the blue wavelength, but this is the more specific, which is in the red, in the yellow and green wavelengths, and melanin for pigment is absorbed in almost all wavelengths, but again, there's a peak in the greens and yellows. And how is this utilized? Well, we want to be able to target pigment, which is in both the epidermis and dermis, and depending on the wavelength, we can specifically target. And this applies to hair removal too. In hair removal, we want something that can be absorbed in the hair follicle, so which is slightly deeper, so we have to use longer wavelengths in general. So important parameters of laser: wavelengths, the pulse duration, how long is that energy delivered to the skin, the power or fluence of the energy, the pulse repetition rate. This is very important when we're treating multiple lesions. We want the rep rate to be fairly high, but not too high that we can't control the application of the laser. Spot size, as I mentioned, wavelengths vary to depth of penetration. Same thing with spot size. The larger the spot size, the less scatter there is of the energy and the deeper the penetration. So where do I start? Which laser do I buy? I have patients that have pigmented lesions. They've been asking for the treatment, and which technology do I decide? How can I decide on? Well, there are multiple technologies out there. In the late 80s, the late 80s was the era of specific lasers, and in this case, for pigment, the Q-switch Ruby laser, Q-switch YAG laser, and Q-switch Alexandrite lasers were developed and came to market. Q-switch means a very short pulse duration. The KTP laser, which is a frequency doubled ND-YAG, works at both 532 and 1064. Again, they tend to be Q-switched. The pico lasers came in the last 4 years or so, and this is another order of magnitude of shorter pulse durations, extremely short pulse durations, and very specific for their targets, in this case, pigment. And they come in various wavelengths. Most of these wavelengths are very effective for pigment. Diode lasers have been around for over 20 years. There's solid state lasers. There's no crystal or gas medium. It's a solid state medium, and they come in various wavelengths, several which are very good for pigment in addition to vascular. IPL, again, has been around for close to 30 years, and this is not a laser. It's a multiple or broadband light source, and very useful for both pigment and vascular. Ablative lasers have been around for over 30 years. These are the CO2 and erbium laser. These are more specific for surface lesions, and if they penetrate too deep, they do have side effects, which I'll get into. Long pulse YAG laser can also be used for pigment. That's more for skin toning, but very effective for some surface and light pigment. Non-ablative lasers, various wavelengths. These are lasers like the Fraxel, which again is non-specific, but is effective with less downtime than some of the more aggressive lasers. Cryomodulation is something that is very new. I was involved in research as part of a multi-center study using controlled cold, not cryo like liquid nitrogen. It doesn't get quite that cold and less side effects, but it's used for pigment, and I'll have some examples. This is currently not available in Canada, but it is FDA approved in the US. So it boils down to, what do you wish to treat? And then more specifically, what can be treated? We want to treat freckles, in some cases, not the little kids with the freckles. I had a mother bring in a 6-year-old many years ago and said, "Get rid of these freckles, I can't stand the freckles." And here's this delightful child with lots of freckles. It was in the middle of the summer. I said, "How about let's wait for about 3 months to see what those freckles do." And she came back in 3 months, and the child had next to no freckles. And I said, "You know what, freckles are protective, and there's a sign that you're getting a little bit too much sun, just avoid it." We don't treat that type of freckle. Sunspots, lentigines, probably the most common type of lesions that we see for treatment. Photo damage in general, which could have some lentigines, some freckles, some non-specific pigment, in addition to vascularity, very effective for treatment. Seborrheic keratoses, especially the pigmented raised seborrheic keratoses, there are multiple treatment modalities, and we'll get into that. Photo damage, as I mentioned, nevus of Ota, a congenital lesion causing pigmentation in the face, typically around the eyes, very effective with the Q-switch lasers. And café au lait can be effective, but a high recurrence rate. What doesn't work? Well, most moles. We tend not to treat moles in general with laser. Melasma, we treat it, we get requests for treatment. Sometimes it seems to be quite effective. In most cases, it's recurrent. And treatment, along with good sun protection and other general advice, can be effective for melasma. Congenital nevi, we don't treat those. What should you not treat? Anything you are unsure of. If somebody comes in with a pigmented lesion and you think, oh, I'm just not exactly sure on that, either get some help by a colleague, refer to a colleague to have it evaluated, perhaps even do a small biopsy, and proceed to treatment if it's applicable. So this is something you don't want to treat. These are called, this is a lentigo maligna, not a cancerous, but a precancerous lesions. Often they can lead to melanoma. These are lesions you should not treat, but they look like a regular seborrheic keratosis. How are you certain that it's not? Well, you can't be 100%. I've been caught out twice on these lesions, and finally it's a biopsy that will confirm exactly what it is. And of course, malignant melanoma, they can be a little bit iffy at times. You can't tell 100% of these. You can kind of tell, and there's the warning signs for malignant melanoma. Definitely do not treat these by laser. So considerations before treatment: know what you are treating, most important. Prepare the patient for downtime and side effects. Take photos, get a consent. Something about the Q-switch and pico lasers and even the IPL, you have to prepare the patients for what they will look like for a period of time. Again, in the early stages of these lasers, it was a learning curve, and we would treat with the Q-switch Ruby, for instance, a person that had multiple pigmented lesions on their face, and they came back 5 days later very, very unhappy because you didn't prepare them for what they're going to look like. It's all crusting and scabbing, and although the end result was remarkable, the interim was not. Discuss the potential for PIH and scarring. Post-inflammatory hyperpigmentation is quite common after treatment, especially in darker skin types. Scarring, less likely, but it can happen. Prepare them, get a consent, get photos. Check if patients have ever had gold therapy. I'll discuss under the complication section what that can entail. And that should be part of the consent for pigmented lesions. Have you ever had gold therapy? Discuss the multiple wavelengths, and repeat treatments are often necessary. It's never a one-time event in pigmented lesions. Make sure you use appropriate operator, wavelength-specific goggles, and for the patients, adequate eye protection, and in some cases, even a corneal shield, internal or external. Most important aspect of these treatments is and most potentially damaging is the eyes. So here's the freckle-faced child that I mentioned. We don't treat this. We let nature take its course, and with sun avoidance, they go away. Lentigines can look identical to freckles pathologically or in the microscope, but they are different. The difference is that they don't tend to fade during the winter months. Here's an early example of a mole that I treated with the, let's see, 97, that would have been a CO2 laser. I did a shave biopsy in the first photo. In the second photo in the middle, that was about a month after the shave biopsy, and or 2 months. And then I treated the area twice with the ruby laser, the residual pigment, and I obtained the photos in the resultant photo number 3, which was very successful in this case. Again, not a treatment that I recommend unless you're very comfortable with the use of these lasers. And here's a more generalized photo damage, a patient with photo damage before and 8 months after 5 treatments with Fraxel laser. Fraxel has many other advantages besides just helping the pigment. It increases the quality of the skin, youthfulness, fine lines, but it is very useful for pigment in addition. These are the types of lesions you're most likely to see and have treatment requested. That's for lentigines. So in this case, quite a dark spot in an Asian patient on the right cheek, following 1 treatment, almost complete resolution. 2 treatments, same thing, using a Q-switch laser. In this case, it was a Q-switched ruby, very effective. Lentigines, this is a Q-switch YAG, very effective after a single treatment. After 2 treatments, in this case with the Q-switch or with a pico laser using the 532 wavelength. Another patient using the pico laser 532. And here are a few examples using a cryomodulation, which is a cold applicator. It's a contact cooling to the skin with the device. It lowers the temperature to around the -10 to -15 range for a specific period of time. And then the sepcara just gradually peels off. This is 1 month after the second treatment. Same thing, 1 month after 1 treatment in this case. 1 month post-treatment again, almost complete resolution. Now you might say, why use the cryomodulation when I have liquid nitrogen, I have other types of laser? Well, the difference is almost 0 discomfort and almost 0 downtime with this. They don't tend to get crusty like the cryo. So it's just another option that has been shown to be very effective. Some common complications: epidermal burns, very common, in fact, expected. Dermal burns and scars, these are largely avoidable, but they can occur. So get your consent, get your photos. Infection, very uncommon, but can occur. Standard post-procedural treatment is advised, and as I say, infection can be prevented. Prolonged erythema, some patients just do not tend to settle down. They can last months and months of redness following the treatment. So make sure patients are aware. That's usually preferable to the pigment of the lesion, but do prepare people for this. Altered texture and grooving, not very common, but can occur, especially with aggressive treatments or multiple treatments. Hyper and hypopigmentation, very common, and they tend to be transient. Paradoxal hair growth, this is another topic, but this is a side effect of the same lasers that we use for pigmented lesions, but used for hair, darkening of tattoos with the Q-switch laser. That is a very common complication. Key points to avoid problems: it's know your laser, know what the wavelengths are, know what the properties of that laser are, know what's to be expected with that laser. Know the skin, have a good working knowledge of the skin of a particular patient's skin. What is their skin type? What is their history of problems? Have they had previous laser treatments or not? What has happened? Look, listen, and feel. Most lasers have an endpoint when you treat the lesion. So look for that end. It might be a slight whitening of the skin. Sometimes some of the lasers you don't want to see whitening. Listen to it. Is there a kind of a crackling sound? And feel it. Is it raised too much after the treatment? Is it too hot. It really shouldn't be, but sometimes inappropriate treatments can cause these changes. Use all of your senses, including the sense of smell. Often these lasers do create a odor in the plume. Most of the plumes from this type of laser are harmless, but it is probably still a good idea to have some sort of a plume evacuation device. Don't be distracted. Talking to the patient, getting feedback is good, but sitting and socializing about what they did last evening during the treatment, probably not advised. You're going to be distracted with that. So here are some of the possible complications that can occur. This is IPL used for some pigment in skin that was probably a little tanned, and probably the fluence is a bit high. Tan skin with IPL, not a good idea. They actually tend to eventually heal quite well, but this isn't the effect that we want to see. And here's what I mentioned before, a reaction to having taken gold in the past. It's a result called cryosciasis. This is a patient who came in my very early days. I can see that's 1993. She had what looked like lentigo on the right cheek. She was treated with Q-switch ruby laser, and a couple of months later, she came in with this kind of a bluish appearance, which after a year was still present. So this is a permanent change to the skin as a result of the gold that she had taken for her rheumatoid arthritis several years earlier. She wasn't on gold at the time. I've since had one other patient with a similar problem. This was probably my fourth or fifth patient that I treated, and luck would have it that this occurred. But it's kind of good that it did occur early, because after that, I asked always if they had patients that had been on previous gold. Gold isn't used anymore, but it was used commonly in the 70s and 80s. And remember, you don't have to treat every patient. If your red flags go up and you're just not quite sure about the lesion, or the patient maybe has too much for expectations, then don't treat them, or get them back at another time after they've thought about it more, or perhaps just do a small test area. Don't get talked into anything. Patients can be very persuasive. They'll say they haven't been in the sun, they have no tan, but you look and think, well, I think they probably have. Get them back. You know, if they go elsewhere and have the treatment and have a problem, that's fine. No one has ever been sued for not treating a cosmetic problem, and that's true. Well, maybe except in the state of California, and Canada seems to be not too far behind. So the big thing, the message I want to leave with you today is know what you are treating before you treat them. There is a place for corneoscleral lenses, and when you're treating near the eyes with these lasers, it's important that the globe be totally protected, because that is the biggest, most serious complication, and it's indefensible if there was a problem. So in 1988, I had two lasers. I had my CO2 laser on the left, and I had my Q-switch ruby laser on the right. They were workhorses for pigmented lesions, for tattoo removal, for different types of vascular lesions. There was no good laser for vascular lesions, no specific one, and these are the ones I used. In 2021, we have so many choices out there for treating not just pigmented lesions, but vascular, fat removal, so many different options. So I think we are truly blessed in this day for lasers. So again, here's 1988, my kids, and here's 1921 or 2021. A big difference. And thank you for joining me today. And if you have any questions, I'd be happy to answer. Thank you.